Thank you so much. Our next presenter is, and I asked him how to say his last name, and he heard me pronounce it, and he said, Bobby, just call me Raj. So Raj is a professor of medicine at the David Giffen School of Medicine at UCLA, Associate Chief of the Division of Nephrology and Hypertension at Harbor UCLA Medical Center. He serves at ASN as chairman of the Dialysis Advisory Group, Associate Ethics of NEFSAP, and a member of the editorial board for the Journal of American Society of Nephrology. Raj is a chairman of the Education Committee of the International Society for Peritoneal Dialysis and a member of the board of directors for the International Society for Hemodialysis. In 2006, he was awarded the John Mayer Award by the International Society of Peritoneal Dialysis. Please welcome Raj.
Thanks, Bobby. Just to say that I'm in Seattle now. I'm at the University of Washington. I'm presenting this on behalf of my work group. The work on this project is complete. I want to acknowledge Jenny, who's in the audience. She's my co-chair, and two other members of my work group, Wendy and Karen. Karen, you'll hear from next after I'm done. So our goal of this project was more immediate, so as to, there are a lot of symptoms that people undergoing hemodialysis have, and we wanted the patients to prioritize for them, for us, which ones we should focus on to develop treatments for. So that is the goal of this project. What we do know is that if you ask people that are undergoing dialysis and ask them all the different kinds of symptoms that they experience, the number is staggeringly high. As you can see, it's a low of 7.5 and a high of 18 in the different studies that have just simply counted all the symptoms patients have. The challenge is that if you look at study after study, there is limited overlap in symptoms that have been identified. I'm just listing it partially. I'm going to go through this very quickly. That symptoms that have been identified by more than 50% of patients are highly variable. There's only one symptom that consistently shows up, and that's fatigue. Other than fatigue, every other symptom is different in different studies. Some prioritize about dry mouth and dry skin, itching, trouble falling asleep. And so as a result of the lack of consistency, it's difficult then for researchers to determine where the focus should be. So the purpose of this project was to catalyze drug development and or testing of currently approved drugs or devices to relieve symptoms in patients with advanced kidney disease. That's the overarching goal. And our approach was to help focus such efforts to engage with a multidisciplinary group of stakeholders and take into account the importance placed by the patient on symptoms, ability to identify therapeutic targets, engagement with industry and dialysis providers, partners, and input from the FDA as appropriate. Just want to make a quick point is that what we acknowledged up front, that the most frequent symptom may not be the most highly prioritized symptom. Because a symptom that is infrequent but causes a lot of distress, the patients may prioritize it higher than a symptom that may be annoying but more frequent. So that is an important thing that we wanted to acknowledge up front. So we've published this manuscript now. It's so that Jenny led the publication off. We had a two-step prioritization by patients. In step one, we undertook focus groups, and we undertook 3, one in Carrboro, North Carolina, one in Seattle, one in Tucson, Arizona. And we invited English-speaking patients 18 to 85 years of age undergoing hemodialysis for at least 6 months and had experienced at least one symptom in the last month. And then, based upon the symptoms that we identified, we undertook a step 2 that was an online survey in which the top 10 symptoms from the focus groups were included. We created a survey, we subjected it to cognitive testing, and then the survey was made available online in mobile applications. And I want to acknowledge DCI, American Association of Kidney Patients, and the KHI Patient and Family Partnership Council outreach that allowed us to recruit patients to complete these surveys, including through social media. So this is just a listing in terms of what we found from the focus groups. We had 32 patients. I failed to mention that the 3 sites we selected were selected to ensure racial and ethnic diversity, so that we wanted to make sure that there was an African American representation, there was a Hispanic population represented, as well as the white population. And we achieved that. We had 44% blacks, 25% Hispanics, and I just want to focus your attention on that the three symptoms that were the most frequent were insomnia, that were prioritized the highest by patients for insomnia, fatigue, and muscle cramping. Fatigue was not a surprise. Insomnia and muscle cramping and how high the rose was a surprise, but this was a consistent message that we got from the focus groups. So these were the physical symptoms, and then we had also asked patients to talk about mood symptoms, and the three symptoms that rose to the top were anxiety, depressed mood, and frustration. So we moved on then to the survey, and then so we had the 10 top symptoms that we had, and had the patients prioritize the symptoms, and so we eventually had 87 respondents from 27 states, so it is not a local response that we had, and 49% were between the ages of 55 and 74, 67% white, 22% black. And so based upon the symptoms that were experienced in the last month, and most important to find better, pardon me, as you can see, the symptoms that were identified as the patients experienced in the most in the last month were insomnia, cramps, and fatigue. But what patients said the most important to find better treatments for fatigue won by a lot, followed by cramps and insomnia. So those were the three physical symptoms that we were going to move forward with. And for mood symptoms, it was anxious mood, depressed, frustrated were the three mood symptoms that rose to the top, of which depression was prioritized the highest. So this is the summary of what I've said, is that we undertook three focus groups. We had a whole range of symptoms that people mentioned. We had the patients prioritize in focus groups the symptoms that were important. 10 of them were tested in this online survey, and we identified 6 symptoms to be prioritized for relief. 3 physical symptoms, insomnia, fatigue, and cramps. 3 mood symptoms, anxiety, depression, and frustration. Frustration is interesting, like we don't recognize frustration as a disease, but frustration was a symptom independent of depression and anxiety patients brought up, and we felt we could not put it aside just because we didn't understand what patients meant by that. Then we had this in-person convening in which we had, what we decided to do is to what are the next steps? It's all good to know what can we bring to the fore to prioritize these efforts. So we had a convening in January in DC, and we had 8 members of the steering committee. We had 5 content experts, 2 individuals from healthcare delivery systems, so one from DaVita, one from Fresenius. We had a CMS representative, we had an NIH representative, and we had industry experts, along with 5 patients and care partners. And we focused on physical symptoms of cramps, insomnia, and fatigue because we were aware of studies that were going on in the field of mood symptoms that we thought that let's just focus on the physical symptoms. And so there are these 7 overarching recommendations that came out of this. The first was that's important to develop definitions for individual symptoms accounting for culturally divergent patient experiences. As straightforward as it is, this is one of the barriers in making progress in finding relief of symptoms. Develop validated and standardized measures for individual symptoms to accurately assess burden. There are a lot of symptoms for which we actually do not accurately have an assessment of burden. For example, cramps is a classic example of a case in point. We actually have no idea how common it is and how do we measure it. Conduct research to better understand the biologic basis for these symptoms in dialysis patients. It may be different than in people not in dialysis. Clinical trials of promising treatments, including drugs, devices, and behavioral therapy. Test modifying dialysis care delivery to support and seamlessly integrate evidence-based treatments that are very challenging at this time to integrate. Demonstrate the impact of symptoms in patient-reported and clinical outcomes, and advocate for payment reform that incentivizes improved treatment and management of patient symptoms. So those are the 7 overarching recommendations, and there were 3 to 4 recommendations for individual symptoms. For example, for cramping, to measure the frequency, duration, and severity. A pilot trial for feasibility and accessibility acceptability of interventions and trial for effectiveness of treatments. There's a lag from the time I press the button to the time the slide moves. Insomnia, to do a clinical trial of CBTI in dialysis patients, to test the effectiveness of site-specific protocols, and test the safety and efficacy of at least one existing drug for insomnia. We recognize that insomnia, a third of Americans have insomnia. In people on dialysis, there's over half of them have insomnia. So it's a lot more frequent than in people on dialysis, but there are drugs that are being introduced for use in the general population, the safety and efficacy of which has not been tested in people on dialysis. And we thought it was important for that to be done for us to see whether those are appropriate for this patient population or not. And then fatigue, which is the most common symptom, is to develop a standardized checklist and workup, a clinical trial comparing usual care versus exercise plus CPT. I hadn't even thought of it, but people suggested there to have a pilot study of psychostimulants to improve fatigue, and then develop a fatigue PRO measure. So those are the symptom-specific recommendations that came to the fore. We were writing Jenny is leading a manuscript summarizing the work from this convening that hopefully will be submitted soon. So to summarize, the burden of symptoms in patients undergoing hemodialysis is very high. Yet there are no therapies approved by the FDA or otherwise demonstrably effective treatments for improving any patient-reported outcome. They just don't exist. The goal for this KHI work group was to spur innovation and further research. And using this two-step prioritization, patients prioritize 6 symptoms for us to focus on. And with this convening, the work group has developed an action plan for 3 physical symptoms. And I have to say that there's a follow-up, like we at the Kidney Research Institute at the University of Washington have a clinical trial funded by an IDDK for treatment of insomnia. And then there is a proposal for a new KHI work on cramping. So there is work that has followed from this already to keep this moving forward. Thank you.